Welcome, everybody. We are very excited, Ellie and I, to be organizing this, what we think was a very important and timely and needed seminar. And this has been evidenced by all the incredible contributions that have been made during the registration by both the clinicians and the investigators. And so our program today is going to hopefully address all of these really high priority issues in terms of an overview of IBM. It will be fast and furious, but it's meant to be an overview so that we can, in the future, take a deeper dive into these topics. So thank you, Ellie.
Yeah, thank you all for joining in. And as Leslie mentioned, we have an amazing program. We try to cover different aspects of inclusion body myositis. And to do so, we had more flash talks, 5 to 10-minute talks. And please be sure that at the end of each session, there will be time dedicated for questions after each session. So please feel free to type your questions in the chat, and each session moderator will read your questions to the speakers at the end of the session. The sessions will be in this order. First, we will hear about the patient's voice. Then we will go with IBM disease mechanisms, clinical trials, imaging, exercise and rehabilitation. And the last session will be about living with IBM with different aspects of this disease. So thank you all, and we will get started with Marie-Christine Breveld, a patient research partner from the Netherlands.
Good day to you all. My name is Marie-Christine Breveld. I'm a 62-year-old IBM patient, and I am the chair of the Stichting Spierziekte IBM in the Netherlands. As a foundation, we raise funds to enable research into IBM, and we work to raise awareness of the disease. Professionally, I was head of an occupational therapy department and later became manager of health centers. I'm very happy to have been given the opportunity by MIHRA to inform you about the patient perspective. What is it like to live with IBM? I was asked to talk a bit more about the hidden impairments and the psychological challenges you face with IBM. In my preparations for this talk, I spoke to two other IBMers, Petra and Stefan. We came to the conclusion that this story might not be the most uplifting part of the seminar. They confirmed my experiences. Living with IBM is hard. I'm grateful to them for sharing their struggles with IBM. Next slide, please. You are probably familiar with what is on this slide, but what does that mean for me as a patient? Number one, because the disease is rare and difficult to diagnose, it happens that despite the hard work and thorough work of GPs, specialists, patients are not too late or misdiagnosed. For me, the same was true. When I started losing my muscle strength, I was afraid of having IBM. My neurologist concluded that it was ALS, also called motor neuron disease. The second opinion also indicated ALS. The effect this diagnosis had on me was one of utter despair, disbelief, terrible sadness, and hideous fear of the future. I was unable to work and had to quit my job. In a very short period of time, I had to make difficult financial decisions, have my house renovated to make it wheelchair accessible. I had to move temporarily, this over a period of 5 months. How I managed all this mentally, I still don't understand now. Eventually, after 6 months, doubt arose about the diagnosis. At that time, I got a new neurologist who told me at the beginning of our first conversation that I had IBM. For him, probably an ordinary day in the consulting room. For me, an announcement that at that time, my brain did not want to deal with. ALS was the sword of Damocles for me. How sure was it that IBM was indeed the correct diagnosis? My neurologist didn't understand why I didn't believe him, but I did not doubt his knowledge and qualities. I did not and could not dare to accept the new diagnosis. It took at least weeks more for me to get that far. A misdiagnosis can have devastating effects. Going through a period of not knowing or misdiagnosis is psychologically incredibly tough. Number 2, and then it's MBI after all, a disease of which the cause is unclear and a cure is lacking. What does that to you? You feel abandoned and alone. It causes despondency. There's a great uncertainty about how fast you deteriorate and which functions you will lose first. You hope it will go slowly, and you lie awake at night worrying. Your future perspective is shattered. For me, it comes and goes in waves. In periods, I can worry terribly about being alone, no spouse or mental carer around. How will that be later? I can't handle the prospect of a nursing home. Am I going to pull the plug then? In the Netherlands, euthanasia is possible. Over here, there are IBMers who do not sit out the ride until the very end. And also, I lost a piece of my self-confidence. That's an intangible piece I cannot put my finger on, but I miss that part of myself, and it saddens me. But distractions give peace of mind. When I sit in the car and drive through the Dutch polder in the sunshine, I'm fine and think, who cares? Losing function of limbs is very hard. You lose more and more. And when you get used to what you can no longer do, you deteriorate furthermore. How do you cope mentally? My greatest hobbies are sailing and walking with friends, but that's not longer possible. I spend a lot of time at home. My swallowing problems worry me. I already find it complicated to have a nice dinner. Talking and eating are not a good combination. Mashed potatoes and beef are no longer on the menu for me, as many IBMers will recognize. Will I still be able to go to social gatherings or restaurants in the future when swallowing really gets worse and eating in public is no longer an option? The disease is isolating and makes your world smaller. To counteract it, I still try to make as many plans as possible and go out. This requires a lot of forethought and planning. Can I take my car close to the location? Are there pavements or steps? Is there a chair available that's not too low and has armrests? Will I not be knocked over in the crowd? Etc., etc. You are on all day to make sure you get through the day safely. This is deadly exhausting. Moreover, IBM is often accompanied by fatigue. You can't prevent everything. Fortunately, by now, I can often shrug my shoulders and look for another solution. I still often laugh with friends about the time in a crowded restaurant when I was leaning on our set table. When standing up, I pulled the wine glasses and the plates over me, making a big mess. I keeps my spirits up but easy, it's not easy living with IBM. Next, please. My motto, living in the moment, take one day at a time, do the things you like, and try to enjoy. Thank you.
Thank you, Marie-Christine. We appreciate your openness, honesty, and sharing your lived experience with us. That's very inspiring to all of us. With that, we will start with the first session about IBM disease mechanisms that will be moderated by Dr. Florine Ernst, a rheumatologist at Mayo Clinic.
Hello, everyone, and welcome. I am pleased to introduce our first speaker, Dr. Elie Nadab. He is a neurologist at the Mayo Clinic in Rochester, Minnesota. He will be speaking today on an overview of IBM pathomechanisms. Dr. Nadab.
Thank you, Dr. Ernst, and I will provide a broad overview of IBM mechanisms without diving deep into any of those, just to provide an introduction of what we know about the disease. A lot of what we know about IBM came from detailed description by pathologists about what they saw on muscle biopsy. and about the uniqueness of this disease that's not seen with any other disease. As you all know, IBM is classified as an idiopathic inflammatory myopathy, also very special. Inflammatory because you see here these red cells, the inflammatory cells surrounding muscle fibers and also eating them out as what's called as autoaggressive inflammation. But IBM pathology is not just inflammation. IBM pathology also include the presence of these pouches here called rimmed vacuoles, which are literally like garbage bags where the cell is trying to get rid of its waste products, but either the disposal system is not working or there is too many waste proteins there that we see here aggregate that they call the congophilic inclusions. Also, IBM has a unique feature, what's referred to as mitochondrial dysfunction. With some fibers, those white fibers here lack this brown staining, which is lack cytochrome C oxidase activity, which are called the CCO negative fibers. So the description of the inflammatory features of IBM have been known since the 80s. And in this seminal paper by Dr. Andy Engel, he used a technique that was so innovative at that time with monoclonal antibodies and was able to demonstrate that the front runner cells here, the ones eating out the muscle fiber, are actually CD8 cytotoxic cells backed up by macrophages. And then work by Dr. Greenberg and his team, they investigated markers of these cells, and they demonstrated that these cells are highly differentiated, meaning they are very mature cells that are not proliferating anymore, and that's why probably they didn't respond to treatment. They tested several maturation markers, and out of these, KLRG1 was the one that thought it would be a good target for a therapeutic trial. Our knowledge about the waste protein there in IBM started with the description of these amyloid-like deposits that shine on Congo red stain. And probably the two most famous proteins in IBM are TDP43, which is a protein that leaves the nucleus and go into the cytoplasm in diseases. And it's a shared protein with other diseases of aging, especially ALS. And also P62, which is a marker of autophagy, that garbage disposal system we talked about. There's a challenge in diagnosing IBM. The main diagnosis relies on biopsy, however, with varying frequencies with different studies, but on average, about 25% of IBM do not have vacuoles or protein aggregates on biopsy. And failing previous criteria, the most common cause for failing was the lack of these protein aggregates. And as I said, there are several drugs. Obviously, there are at least 3 more in the slide that have been tried in clinical trials and failed. That's why, as of today, there is no evidence-based pharmacological treatment for the disease. And those peculiar aspects sparked an ongoing debate. What causes IBM? Which came first, the chicken or the egg? The inflammation or what's called the degenerative changes? And there are several theories there. We don't know which one is true. Probably the traditional theory or the most discussed theory is IBM is a primary inflammatory disease. So there is something that stimulates the immune system, some antigenic stimulation, and that particularly stimulates CD4, CD8 cells that proliferate, and eventually with time, they become highly differentiated and highly cytotoxic. And they secrete a lot of cytotoxin and induce a lot of inflammation that causes so much stress to the cell. And as secondary changes, we start seeing a protein aggregation and other features, other degenerative features. And the biggest support for an inflammatory aspect of IBM is actually the pathology, also the association with one of the HLA gene, but just a single one that's shared with Sjogren syndrome. And also on RNA sequencing, IBM is one of the diseases with the highest level of expression of immune-related genes, especially related to immunoglobulins and T cells as well. However, the theory fails to explain several features of IBM. One of which is IBM, it's a disease of aging. There is no juvenile form of IBM. It's a strict disease of aging. It has male predominance, twice more likely to be male, unlike any other disease. Most importantly, there is no treatment responsive window that if we miss, the inflammation becomes not treatable. from day one, IBM patient, even on biopsy, many of them have all these features. Even at the preclinical stage, when we catch the disease early on with an antibody and high CK level, they have these features already present. The second possibility focuses on protein aggregation. We still start with the inflammation that triggers problem with protein homeostasis. And these protein aggregates start bothering everything around them. The nucleus with gene transcription, start disrupting the mitochondrial function, and so on and so forth. The one thing with this hypothesis is that protein aggregate, at least on biopsy, they're not universally present, and they probably, possibly, not with certainty, occur at later stages of the disease. Similar to the first one, we don't have a treatment-responsive phase in IBM. And last is a theory that IBM is a strict degenerative disease. Degenerative disease are neurological disease that happen with aging, for which there is no treatment yet. However, these terms are still very broadly described in IBM. It's more of a broad term that we don't know exactly what it entails. With that, in the last few minutes, I'll share a little bit with you about my research that focus on IBM as an aging disorder. And forget this busy slide, maybe I'll take it off and tell you about it. The general concept there that for IBM to happen, you have to have an aging milieu in that muscle. Each of us age differently. Our mitochondrial function age differently, our metabolism age differently, but there are certain aging factors that has to be present, which at a certain moment, for unknown reason, unknown additional triggers, start more a cascade of events that I'll give you one example, that they become self-sustained and destructive to the cell. And these are shared mechanisms with other diseases of aging that they are too complicated for our understanding today. But there's been a lot of advancement in the field, one of which is mitochondria is no more considered just the powerhouse of the cell that produces energy. The mitochondrial role is very more detailed. And the mitochondria is involved in cell metabolism, calcium regulation, but also it's a signaling organelle. Signaling organelle, meaning it's an organelle that makes important decision in the cell. It can regulate the immune system. It can tell the cell when to die or when it's better to heal itself versus when it's better for the cell to just die. And there are also a lot of sex differences in IBM that by understanding, we could understand the difference in the disease and why female have a little bit more resilience to the disease. What we know about mitochondria in IBM has been mostly consisted of that we know that the cytochrome C oxidase negative fiber are present in almost every biopsy of IBM. There is high mutations in mitochondrial DNA in IBM, and IBM muscle have low mitochondrial content. So in our research, we aim to deeply characterize the various aspects of mitochondrial functions, behaviors, morphology, signaling. It's not a binary thing. It's not mitochondrial dysfunction, yes or no. It's how is the mitochondria involved? Where is it playing a protective role versus destructive role? Where could it benefit from other mitochondria targeted or aging-related therapeutic that are in development? And for the sake of time, I will just show one example, which the main function of the mitochondria to prevent inflammation is mitophagy. So with that, we looked at 38 IBM patients and controls, and we did first untargeted RNA sequencing. And the top, among the upregulated pathway, the top upregulated pathway was the NLRP3 inflammasome. And among the downregulated pathway, there are several mitochondria-related pathways. And these are validated in other cohorts. If you look at the published series, the NLRP inflammasome is hidden there in the top 10 in most of them. But also we tried to see what's different between males and females. So we identified the genes that are unique to females in red and the genes that are unique to males in blue. And it gives you a little bit of sense of what's going on with the females upregulating their defense mechanism, their defense to stress, their defense to immune attack, while males are upregulating more cell migration, and which would propagate the disease further and which would help with disease propagation. And also what controls from these inflammasome activation is mitophagy. And this mitophagic marker is markedly elevated in IBM, but most significantly in males and much less in females. And all these alterations occur in type 2 fibers, which are known to be prone to metabolic derangement and mitochondrial function. And they correlate with clinical parameters, again, more so with males. So summary slide about that. It's possible under normal condition when mitochondria is challenged, they secrete some molecule there that triggers inflammation. And normally with intact mitophagy, autophagy, you get rid of those inflammasomes, you get rid of the damaged mitochondria. With altered mitophagy and autophagy, that inflammation triggers further stress, further inflammation, further mitochondrial dysfunction. And this is one of the vicious cycle, that detrimental cycle that occur in the cell. To wrap it up, I think in aging-related disorder, determining the original inciting event, what originally caused the disease, I think it's still beyond our capacity with current technology. However, understanding these vicious cycles and trying to approach the disease from a different aspect to widen our arsenal of drugs to be used could be beneficial in IBM, where we could borrow other drugs from other aging-related disorders. Thank you for your attention.
Thank you very much, Dr. Nadav, for your enlightening talk on the pathomechanisms of IBM. As a reminder, I will be taking questions in the chat at the end of this first session, and we will have 5 minutes for questions to both the speakers. Our next speaker is Dr. Jorge Chapa. He is an immunologist at the University of Washington in Seattle, Washington. He will be speaking on mitochondria and inflammation in IBM. Thank you, Dr. Chapa.
Thank you for the kind introduction. Good morning, everyone. I hope you're doing well today. So I will be speaking and sharing a bit of our findings that we have been some of the research we have been doing under Dr. Christian's Loop Lab. And he's a very important researcher in these kind of diseases and has basically spent a long part in his career studying these type of diseases. So let's begin. Here we go. So just as a tiny introduction for everyone. So Dr. Eli has already spoken like very well about mitochondria, but just as a tiny reminder, so what are mitochondria? What are these kind of things? So every cell in our body, or almost every cell in our body, especially the ones in your muscles, have a lot of mitochondria. These are very tiny organelles that, as Dr. Eli said, they're not just the powerhouse of the cell. They have many different functions, and most of them are actually basically unknown for us. So we're still doing a lot of research for trying to uncover, like, okay, what are these things really for? But these are just some of the functions that we have been discovering along these long years in research. Powerhouse of the cell, heat regeneration, helping fight infections, cell death control, as Dr. Eli was saying, brain, muscle health, and many other tissues basically held. However, something interesting happens in IBM that because of a reason, we don't know why, this is basically unknown, as Dr. Eli was saying, some of the mitochondria that patients have with IBM, they get free into circulation. This is a blood vessel. And they're basically also having a dysfunction in the muscle tissue. We don't know why. And when these mitochondria go actually into circulation, some proteins related to them will actually also go into circulation. As an example is the GDF15, which we have been like measuring in IBM plasma. And another one is formulated peptides, which we have been also measuring in IBM plasma. So this is kind of interesting because we have correlated these levels of proteins of mitochondria related to mitochondria with inflammation, and there's a very strong correlation. So somehow these mitochondria are releasing some other proteins into circulation that will be causing some inflammation. Inflammation where? Many parts of the body, but specifically in muscle. So this might be helping us and everyone to understand why IBM causes basically muscle dysfunction, weakness in other words. So now in our lab, we have been trying to find out which other kind of cells is also related to the inflammation. And we found that there's a specific cell besides T cells and many other cells that have already been reported that actually are causing this inflammation. And these are the neutrophils. These are basically the soldiers of our body. This is one of the most abundant cells we have, white blood cells in our body. So these neutrophils will be activating because of a particular reason, maybe probably to this protein called fMet and many other proteins related to mitochondria, and will be releasing some peptides and some activation markers that will be probably hurting the muscle. The thing about this is that these peptides can also be detected in circulation because once they're released, they will be detected. And in the lab, we found that if we somehow stop a bit of this activity of the neutrophils, this can be also correlated probably with less muscle affection. So if we control somehow these soldiers, do not be overreacting, probably we'll be seeing very good outcomes for not having a lot of weakness in these kind of diseases. So with this, we have like in plasma, we have been measuring a lot of biomarkers that are helping us to establish an early diagnosis of the disease, and not just that, to establish probably also how patients are responding to treatments. So, and these are just some of the biomarkers we have been measuring around. And also, of course, together with this, we have been trying to find therapy options and treatment options. Among them is trying to stop neutrophils. The other option, and because of time, I'm not showing a lot of that, but it's mitochondrial transplantation. So if patients have mitochondrial dysfunction, maybe one of the therapies will be let's replace mitochondria. And there's some research on that, and just sharing also some things. Even NASA is trying to do this transplantation in astronauts for trying to have the astronauts not affected by microgravity and many things for having their muscles, not losing also mass. So it's a very big topic, and there are many people working on this. I guarantee you. So basically, as all these will generate a better outcome for everyone. So if we have biomarkers, if we have therapies, all the patients with IBM will have a better quality of life because they can have an early diagnosis, they can have an early treatment, or once they have like the disease diagnosed, the prognosis will be much better. And as a conclusion, I will be sharing this picture, which is part of one of the papers is currently under review. That we are trying actually to explore the mechanisms in which patients are developing basically muscle weakness. And the conclusion is basically not science related for this time. This conclusion is for you, for all of the patients. So just as a tiny reminder that every experiment, every late night in the lab, every question we ask is basically driven by one goal, and that is to understand better IBM, understand better the disease, and to try to find things that bring us closer to real answers, real treatments, and a better quality of life. So just a reminder for all the patients here who have this disease, you are the reason we are doing this research, and we are here to help. So thank you for that.
Thank you very much, Dr. Chapa, for your talk on mitochondria and inflammation. We'll take about 2 minutes if anyone has any questions in the chat for our two speakers.
We would also be happy later on if any question come up to answer it in the chat by typing as well.
Very good. If there are no questions, then in the interest of time, we may move on.
I am now going to introduce Dr. Marilee Needham, who is joining us from Australia, and I'm going to ask Marilee to please introduce yourself as the next moderator to our next session.
Hi, thank you, Leslie, and thank you, Ellie, for organising such an amazing international session and bringing us all together. So I think this is such a great opportunity and hopefully the first of many. My session is on the clinical trial landscape, and I think that's an exciting space in IBM. And our first speaker is
Dr. Mazen Damachki.
I'm a neurologist at the University of Kansas Medical Center. Most importantly, we'll talk about recently passed clinical trials that I've been involved in and current trials that we're involved in, as well as future directions possibly for studies in inclusion body myositis. We were very disappointed in the result of this international study that I oversaw, looking at inducing heat shock protein using specifically arimoclomol to induce heat shock protein 70 as a chaperone protective agent in patients' muscles with IBM. Unfortunately, there was no evidence of efficacy across outcome measures. However, we learned quite a bit about design of clinical trials, and most of you know this, that there was a European Neuromuscular Center meeting that occurred in June of 2023, during which we talked about study design, duration of studies. And one of the benefits of the study, however, is setting kind of the benchmark of what the current clinical trials look like and what outcome measures should be considered in IBM, though we have some room for improvement. So jumping into the current studies that are ongoing, Professor Olivier Benveniste had led the study that was published looking at using sirolimus, rapamycin in this case, in patients with IBM. These were 44 patients with IBM. The study took place in France, half of whom were randomized to receive sirolimus, the other half receive placebo. The reason for exploring sirolimus is multifaceted. IBM being a complex disease, there's impairment of autophagy, there's clonal cell expansion, there's impairment of Tregs, regulatory T cells, and then there's mitochondrial pathology, as mentioned earlier on by Elie and others. So it made sense, since this drug interferes or promotes the health of these targets, to pursue that. And in Dr. Benveniste's study, though the primary outcome of knee extension was not improved at the timeline, however, there were several different outcome measures, secondary outcome measures, that showed promise. So Dr. Needham here led the effort of an international study across Australia, US, and Europe that's currently ongoing, looking to evaluate in a larger patient population whether this drug is effective in IBM. Of course, we know the story around the killer cell lectin receptor G1 expression on these terminally differentiated T cells, which is the other aspect of IBM pathology, an important aspect that's been long recognized. However, the KLRG1 discovery is a recent one that Steve Greenberg and colleagues described that led to the development by a company named Abcuro of an antibody that was initially tested by Dr. Needham in Perth, Australia, as a phase 1 study, safety study, in a small group of IBM patients, showed promise. And all of you know now that the large phase 3 study has completed enrollment of both Group A and Group B, and we're hopeful in the next year or so that we'll know the result of this approach of killing off those very differentiated cells as to whether these help in IBM. Now, some of you may be excited about stem cells in IBM. I'm aware of 2 stem cell studies going on in IBM. One of them, Professor Benveniste is conducting at Salpêtrière in Paris, France. The other one is a study that we're completing here at KU for a safety study of stem cells in patients with IBM. We're injecting the flexor muscles in the arm as well as the quad muscles in a geographic localization area. We've shown so far safety, and we're hoping to expand this into a larger set of study that looks at efficacy of stem cells in patients with IBM. The rationale being stem cells can be not only promoting growth of new blood vessels, They might differentiate into muscle fibers, but that's not the main mechanism. But they also have an anti-inflammatory mechanism of action. And then the measuring stick for success in IBM studies have been really difficult. We use right now an instrument called the Inclusion Body Myositis Functional Rating Scale. We all know this is a good instrument. However, sometimes as raters in the clinic, measuring the IBM-FRS can be tricky for the patients when they don't fit within the category number 2 or 3 on any of the items. So there's a bit of a guessing component there, or just a gestalt component, let's put it this way. So in order to get around this, I'm working with a company called Biosensics, and with a research study that's supported by Apcuro, by Myositis Support and Understanding, and GettingUp.org, looking at having the trajectory of IBM defined using in-home biosensors. So what we're doing in this study is having patients followed up first at the 3-month time point and the 6-month time point, and every 6 months for 2 years. And during those epochs, at those time points, patients wear those biosensors measuring leg activity and arm activity for a week epoch, day and night. They're resistant to showers and whatnot. And with the idea that we want to detect progression of disease better, and therefore, if drugs work for IBM, be able to tell better. So far, we've shown very strong correlation with the leg IBM component of the IBM-FRS of these biosensors, and moderate association with the arm component of the IBM-FRS. So we're on track. The study is underway. So most of you now want to know, well, what's in the future? What are the studies coming out of the pipeline? And these are my thoughts about what should be explored in the way of studies, some of which were described to you earlier on. They're not a surprise. But there's a thought process based on this paper published in 2023 in JNNP that some of the antibodies structures may be pathogenic in animal models. Could it be that targeting the antibody is an approach? That's one thought process. We tested one chaperone, and that didn't work. We have safety data right now on another chaperone, and we're planning to submit the grant to the FDA. So maybe looking at other chaperone that promote the health of muscle fiber, promote autophagy, in other words, and therefore protect muscles from degeneration. Mitochondria, they're important components. I promise I did not add the mitochondria after Ellie's talk. These were clearly important targets. And we have an idea. We're pursuing a research study, early stage research study in mitochondria and IBM. Other novel targets target inflammatory cells. KLRG1 targeting is important, but we now know in other autoimmune diseases, lupus and others, there are other methods to target inflammatory cells that could be promising. Stem cells, we talked about. We don't talk too much about exercise, but Dr. Diedrichsen in Denmark did a blood flow restriction study with exercise and showed benefit in sustaining muscle strength in IBM better. So this is a powerful tool. It needs to be explored some more. And I think ultimately what's going to help IBM patients is not a single drug therapy. It's going to be a cocktail of therapies. But we first need to get to the first step, which is identifying at least one single drug that works for IBM patients. We owe that to our IBM patients. Thank you for your attention.
Thank you very much, Mazen, and thank you for introducing yourself. Marianne, we're a bit over time, so we might just go straight to you, if you're happy to.
Can you hear me
going.
now?
Yes, we can. Perfect.
Okay.
Thank you.
Yes. Thank you. Despite intensive research efforts, there is still no effective treatment for IBM. And one of the greatest challenges lies in its complexity. IBM is thought to involve inflammatory and myodegenerative pathways, as you heard in a previous talk. Trials focusing on the former, administering drugs which are beneficial in other idiopathic inflammatory myopathies, were not effective. And there are other trials. Dr. Dimachki updated us on a number of trials that are conducted. And of course, we have high hopes of a positive outcome. However, we need to be ready for additional trials, and therefore we have to select appropriate outcome measures and biomarkers. And one of the challenges is the variability in disease phenotypes at an early stage, which complicates the standardizing of interventions. Bhaskar Roy conducted an excellent review on clinical outcome measures, and he found that all these outcome measures listed in the red circle were used as primary outcome measures in RCTs. Based on the results of a consensus meeting, also referred to by Dr. Dimaczki, attended by experts from all over the world, the IBM FRS was selected as the most appropriate outcome measure. And this was also found in a recently published retrospective study by Scott and others from the research group of our chair. During the consensus meeting, biomarkers were discussed as well, and there was agreement that quantitative MRI could well be used for monitoring progression of the disease. We are all looking forward to the data from the INSPIRE IBM study led by Tahseen Mozaffar. This is a prospective natural history study on 150 IBM patients who will be assessed every 6 months over 2 years. The study aims to determine whether anti-CN1A antibodies mediate disease progression. The rate of disease progression and severity as measured by the IBM FRS score and timed get up and go. The decline in respiratory function and the presence and frequency of variant T cells in the serum and skeletal life. Biomarkers can be classified into several key roles, as you can see here. Muscle imaging like MRI and ultrasound can be used as biomarkers for diagnosis, and MRI, as you can see here, also allows for monitoring of progression of the disease, as mentioned previously. Immunophenotyping of IBM blood T and natural killer cells, and proteomics revealing promising metabolic fingerprints may be predictive biomarkers. Pharmacodynamic biomarkers focusing on the mechanism of action, for example, the observation that cytotoxic CD8 positive T cells destroy the muscle, in particular T cells with the KLRG1 marker. And this has also been referred to by Mazen. Currently, a trial is being conducted in which KLRG1 is targeted, in contrast to broad T cell targeting, which has been unsuccessful. A non-invasive PET-CT biomarker, you can see it here, has been developed as a research tool to assess CD8 positive T cell muscle invasion in IBM and can be used as a biomarker for diagnosis, disease activity, and therapeutic development. Risk falls may be predicted if there are lower IBM FRS scores and increased time to complete the timed up and go. The increased fear of falling may negatively impact a patient's quality of life and ability to participate in social activities. And this is currently being investigated. However, a number of outcome measures and most of the biomarkers need to be validated in longitudinal studies. And in particular, appropriate outcome measures need to be developed for hand dysfunction and swallowing impairment, which, as we heard from Marie-Christine, have a huge impact on daily functioning of the patients. There have also been studies showing research gaps regarding social and psychological health-related quality of life. And the same holds true for patient-reported outcome measures reflecting life impact of people with IBM. These prompts have been developed by the OMERACT group at the bottom left. For the other myositis subtypes, and this was not a trivial process. It took more than 13 years since numerous steps have had to be taken, and they are listed on the right side of this slide. These steps include identification of the right domains and of valid, reliable, and responsive instruments. And therefore, this last slide is a research agenda which requires sufficient funding, manpower, and close collaboration with patient research partners. Thank you for your attention.
Thank you so much, Professor de Visser, for that fantastic talk. I am going to just whip through my talk because I'm mindful of the time. Can you all see my slides?
Yes.
So I'm just going to touch on the challenges with clinical trials in IBM, and I think they've already sort of been addressed by both our previous speakers. I guess what is success for an IBM clinical trial? I mean, ultimately, we would love, firstly, to prevent the disease. But if we can't prevent it, we'd love to cure it. And if we can't cure it, at least most of my patients say to me, if I could just stay the way I am right now, I would be happy with that instead of facing the progression that currently is the natural history. So what do we measure for success? And I think we've just heard a whole lot of a beautiful talk and exposition by Dr. de Visser around this. We have to consider how we measure things, how repeatable they are, how acceptable they are to patients, how reliable they are for us to test in different sites around the world, and how sensitive to change are they. In IBM in particular, there's the measures that we've discussed already, the IBM FRS, 6-minute walk test, muscle strength or quantitative muscle testing. And then there are the other biomarkers, both radiological and blood markers that Professor de Visser just went through. But there are a whole lot of other factors we also need to take into account. We need to see what's acceptable to patients and what's meaningful to patients, what's acceptable to regulators, what's going to get a drug licensed for a particular condition. And there's a whole lot of other things that we consider when looking for outcome measures. Then once we decide on what the outcome measures are that we need to measure in IBM, then we need to decide what's the primary one, what's the most important one, and then what are some other important ones and what are some secondary outcomes that we need to measure. And the most important outcome, and everybody agrees on this, is what's important to patients. And really what's important to patients is quality of life and continued function over time, function over strength. And that's why we've shifted from testing quadriceps strength to looking at the IBM FRS. But we need to look at how effective a drug is at modifying the natural history of disease and how tolerable and safe it is for patients to take. And then, of course, Professor de Visser has already touched on that we need to address upper limb function, swallowing, in addition to just leg function and walking. One of the tricky bits when you're designing a clinical trial is working out how many patients we need to test it on and how long does the trial need to go for. How many patients do we need to see a difference between treatment and the natural history or the placebo arm, particularly if you're looking at slowing the disease trajectory? And how long do we need to run that trial to see how divergence from that natural history progression to slowing or stabilization of disease? And these are both difficult questions to answer. And these are where prior trials like the arimoclomol study that Professor Demarchki described are really important in helping inform future trials. So for patients that turn up and get lots of measures for clinical trials, you're helping not only work out if that drug is effective for IBM, but you're helping us design the next IBM trial even better. There are international challenges when we're running trials across borders, and for a rare disease like IBM, we often need and want to include as many patients as possible from around the world. There are rules around data sharing and governance of data, contracts, legal implications, insurance, funding, and obviously time zones. So for those of us in the east part of Australia, it's nearly midnight or past midnight. New Zealand, it's very early in the morning, and very early in the morning for our US colleagues. And this is this is something that investigators face when we're all trying to catch up and meet about clinical trials. Of course, funding is a big issue, and I don't need to go into that, but clinical trials are really expensive. Naively, I started the sirolimus trial thinking if Pfizer gave us drug, we had a common protocol, we could all just follow it, and it would be relatively cheap, but I was wrong. So how do we succeed? I'm going to follow Professor de Visser. We need a strong network of collaborative clinical teams. We need to work together. We need to have dedication and partnership of the site teams. We need the patient collaboration and support for these. And we need the patients and clinicians together to fundraise to support these efforts. So thanks for your attention. I'm aware that we're over time. There was one question in the chat before I started my talk. And Mazen, I'm hoping, you've addressed it in the chat about funding clinical trials with the changing landscape in the US.
Yeah, I can put it in the chat. I sent it to you. I don't know if it's public all around, but I can just repeat what I mentioned there very briefly, that clearly when we have submitted grants to the National Institute of Neurologic Disorders and Stroke, NINDS, they have no interest in inclusion body myositis. The entity that usually contemplates myositis and muscle disease is NIAMS, the National Institute of Arthritis and Musculoskeletal Disorders. But again, this is a tough hill to climb, and the pathways are difficult. And where we found success in funding is through the FDA Office of Orphan Product Division. The problem being, however, as we all know, the funding landscape is changing in the US dramatically, and it creates a lot of uncertainty about what the future holds for all studies, including IBM studies. Apologies for not being more optimistic.
Thank you, Mazen. I'm sorry to turf that question to you, but I think you have a clearer understanding of the US landscape. Pushpa from New Zealand has, it sounds like she's got the TLGL. That's a lymphocytic leukemia that's quite commonly associated with IBM. And we do see that in quite a large proportion of IBM patients, depending on how you define it. And CK levels, we do see that with methotrexate and prednisolone. But unfortunately, some of the natural history studies and retrospective studies seem to suggest that even though we might see a drop in the CK, that doesn't necessarily mean the disease doesn't progress despite that. So, I mean, it'd be interesting to see how you go, Pushpa. Are there any other questions? I think we probably need to move on, if there are not, to the next session. We're already slightly late.
Yeah, thank you all. We'll move on to the next session, which will be about imaging in IBM, and it will be moderated by Dr. Bing Liao, a neurologist in Houston, Texas, at Houston Methodist.
Hello, everyone, and thanks, Ali, for bringing us all together, and it's good to see you after so many years. So our next speaker is Dr. Pedro Machado. So Dr. Machado is a professor and consultant in rheumatology and neuromuscular disease at University College of London. So Dr. Machado's topic is MRI in IBM.
So, well, first of all, thank you for the invitation, and it's a huge pleasure to be here today, and with such a big audience as well. So I'll speak a little bit about the use of MRI in inclusion body myositis. As you've heard, I'm an academic clinician working at University College London in London, and I've got a clinical and a research interest in this enigmatic condition. Okay, so MRI in the context of myositis, in the context of the idiopathic inflammatory myopathies, can be used to support diagnosis and the monitoring of the various conditions. So, for example, it's very useful to use MRI to distinguish between muscle inflammation and chronic changes, which is perhaps a little bit more relevant in the other idiopathic inflammatory myopathies compared to IBM, but obviously both coexist. So it can be used to assess disease activity and damage and the severity of the condition. During the differential diagnosis process, the pattern of involvement, so by pattern I mean which muscles are affected, and in what extent they are affected, for example, by fatty infiltration, where the muscle is being replaced by fat tissue, fatty cells. So that pattern can sometimes help to distinguish IBM and the other myositis from mimics, from, for example, some genetic myopathies, such as the limb-girdle muscular dystrophies, among others. Distinguish other types of myositis. It can also be helpful to select the muscle biopsy site. So we can, looking at the MRI and which muscles are affected and in what extent they're affected, it can be a very helpful tool to select the muscle biopsy site. So, for example, if a muscle is already replaced by fat, largely replaced by fat, we should avoid that muscle because then the muscle biopsy might not be informative. And more recently, well, maybe not that recently, because we've been working on this for almost a decade. MRI has been explored as an outcome measure, as a biomarker, as a tool that can also be used in research studies. And I'll show you some data about that. And finally, I think it can also be a useful tool to communicate with the patient. At least I do it often, and I think patients are interested in that information. So I often show the patients the distribution and of changes and how that relates to the symptoms they experience. So it can be an aid to understand the disease and something that we can be shared with the patient. So this would be the conventional MRI that we use for clinical purposes. And in panel A, we have what is called a fat sensitive sequence, where if it's fat sensitive, fat is bright. And then the top image here, it's at the mid upper thigh level. The middle image here in panel A, it's at the lower thigh level, and then the lower image here is at the calf level. Okay, so thigh and calf. And then B is the same patient as A, but with the MRI scan having been done 5 years apart. And I think all of you can see the changes. If the white bit is fat deposition, you can see that the muscles here are quite abnormal. So this would be the normal, let's say, iso-intense signal, this gray signal of the muscle, right? And then the white represents fat, and obviously there's the subcutaneous fat tissue. But what is abnormal is that the muscle is becoming infiltrated by fat. So that's what's abnormal, and then it's causing muscle atrophy, and there's a replacement of the muscle by fat, which will obviously lead to weakness and all the functional consequences of it. But when you look at B, it's much worse. So obviously this has a huge impact at the individual level in terms of the mobility of the patient. And we can clearly see that even without a lot of expertise in MRI. But MRI is also useful to detect inflammation, and that's what we have in panel C, which is what we call the water-sensitive sequence. Now, when there is inflammation, there is an increase in water content, either because there's an increase in the amount of vessels, there's hypervascularization of that area, or because there's an inflammatory infiltrate, and therefore there's an increase in water content in that area. So all this bright signal that you see in C, that represents inflammation. And we know that this is one of the features of IBM, this interplay and this combination of inflammation and degenerative changes. Now, there's a pattern that has been described as being useful at early disease stages, whereby the fatty infiltration is more prominent in the quadriceps muscle, which again mimics what we see clinically, where the quadriceps knee extension is initially one of the muscles that is more commonly affected in IBM. And what is interesting is that one of the muscles of the quadriceps, so the quadriceps has 4 muscles, the rectus femoris, the vastus lateralis, vastus medialis, and the vastus intermedius. Usually the rectus femoris, which is one of the 4 muscles of the quadriceps, is relatively spared compared to the other 3. This cannot be seen here in this image. And again, this does not happen in all the patients, but it does happen in a large proportion of patients. And the other very interesting finding in IBM is that in the calves, in the gastrocnemius muscles, so we have 2, the medial and the lateral gastrocnemius, and you can see here that the medial gastrocnemius, MG, right, is much more affected than the lateral gastrocnemius, which here on the left, I would say it's not even affected. On the right side, there's some fat infiltration, but obviously much less than the medial gastrocnemius, which is completely replaced by fat. So this is a very typical pattern of inclusion by the myositis. And as I said before, these patterns can be useful in the differential diagnosis with other muscle conditions, namely genetic myopathies. Now, what we, in a kind of semi-quantitative way, we can say that, okay, this area of the muscle is less affected than this one, and this one is less affected than this one, and we can kind of grade this. So this would be like grade 1 fatty deposition, this would be grade 2, and this would be grade 3. But this is all a bit subjective, right? And it's not very accurate, it's not very reliable. If you ask someone else, they might say, actually, 2 looks more or less the same as 1, so I'll give it a score of 1 there. So we've been looking at ways of quantifying this in a much more reliable and exact way, let's say. And that's called quantitative MRI. So for example, this one, it corresponds to 12% fat deposition, 2 16%, and 3 would be 38%. Now we do this using special MRI sequences, and namely the Dixon sequence, that are able to separate water from fat. And then we build what is called a fat fraction map, which is essentially a map of all the muscles. And for each one of these muscles, we attribute a percentage of fat infiltration. So from 0 to 100%. So the more fat, the higher the percentage, obviously. And this can be used to track the disease over time, to monitor the disease over time. And it can be very useful in the context of research and clinical trials, because these measures, and we've shown that, are very sensitive to change, and they are very reliable. So another measure, in addition to fat fraction, is the cross-sectional area, or the related concept of remaining muscle area. So remaining muscle area is essentially the muscle volume fraction that still contains the contractile muscle, the working muscle. So you see, for example, here, an example of a patient where fat fraction is low. Actually, this is a control subject, so a healthy subject without IBM. So here the fat fraction is only 2.3%, which is normal, very small percentage of fat. You can see here that the remaining muscle area is a very large area, so 63 square centimeters. And this subject is able to produce a large force. So this is a newtons, which is a measure of strength, let's say, and you can see it's 178 newtons, so that's very high. But then if you look at this image here from a patient with IBM, you can see that the fat fraction is 43%. Okay, so there's a huge amount of fat infiltration. When you look at the remaining muscle area, so the working muscle, let's say, it's only 17 square centimeters, so completely different from the 63 in the healthy individual. And obviously the strength, it's much smaller. So this subject is only able to produce 18 newtons torque strength. Okay, so you see that all these measures, they correlate with strength and functional parameters. And over the last, I would say probably 10 years, we produced a lot of evidence about how MRI can be used to track changes over time in patients with IBM, how this correlates with functional and strength measures. We've shown that these are sensitive to change over time, and they can also be used as like a mechanistic approach to look at muscle morphometry and composition in people with inclusion body myositis. And I won't go through all the details because obviously I don't have enough time, but potentially they could be used as primary endpoints in early phase clinical trials, because if they're more sensitive to change, more responsive, they could allow a decrease in the number of subjects required in a clinical trial to show efficacy of a drug. So in early phase clinical trials, it would make sense to use this as, for example, a primary endpoint. And then in late stage clinical trials, we would shift to a functional parameter, because obviously that's also what the regulatory agencies ask for. But it would make sense, for example, in a phase 2, maybe to use MRI as the primary endpoint. Okay, so in conclusion, MRI is of value in the assessment of IBM. It can help with the diagnosis, monitoring. It can help select the muscle biopsy site, and it can also help communicating the disease aspects to the patient. And finally, it is now, I would say, an established and a valid and sensitive biomarker in IBM that could be potentially also very useful in the research context in early phase clinical trials. Thank you.
Thank you, Dr. Machado. So we're going to move on swiftly to our next speaker, Dr. MIHRA Abeyda. So Dr. Abeyda is the Associate Professor of Medicine in the Division of Rheumatology at Johns Hopkins, and she's also the Director of Musculoskeletal Ultrasound and Injection Clinic. So her talk will be ultrasounding IBM.
Okay, thank you so much to everyone. And thank you again to MIHRA for the invitation and this great seminar. So thank you, Pedro, for your great talk. I can just build on that, actually. So now I just wanted to show you also some of the work for muscle ultrasound. Oh, and IBM, and really show you how this tool can be useful in our assessment for IBM, right? Especially as a point of care tool. It's available at the bedside. I can look at as many muscles as I want. It's not claustrophobic, right? It's very comfortable for the patient. And so just as a refresher, this is the normal structure of your muscle. So we can see that every muscle is made up of individual muscle fibers that are then grouped into fascicles. And each fascicle is invested with its own connective tissue called the perimysium septations. And then you have a group of fascicles that then make up your entire muscle. And each muscle is invested by this fascia or epimysium. So that structure is very well visualized on ultrasound. And in fact, you'll see here that the resolution of ultrasound is far higher for superficial soft tissues like muscle. So MRI and ultrasound can give us different information. So if I'm orienting you here to what a normal muscle should look like, and it tends to be very gray or black, and then you end up seeing these whitish flecks inside the muscle, and that's representing the perimysial connective tissue I had mentioned. And then each muscle is bound by this white fascia again, so you can tell one muscle from the next. And when everything is healthy, in a cross-section, you can see all the different layers. You have skin, subcutaneous tissue, you have your muscle, and all the way you can see down into the bone. And longitudinally, you can appreciate that nice parallel orientation of your muscle fibers, and you can see very nicely when it dynamically moves. So in myopathies or muscle diseases, and no different from myositis, we know that the main parameter we're looking for is how the muscle turns whiter, or the gray scale value of that muscle. So this is a normal muscle, a normal biceps muscle for reference on the left. And usually when we do muscle ultrasound, we standardize everything. We have to keep the settings the same. We actually get the same depth. So we know we're comparing apples to apples. So ultimately, if this is a normal muscle on the left, what you have here is an example of a necrotizing myopathy. This one is an acute dermatomyositis. And finally, your IBM muscle here, a similar biceps muscle. And you'll see that in myositis, definitely your echo intensity goes up, so it's a whiter muscle, but also you're losing that nice architectural feature of the muscle where you lose the contrast between your connective tissue and your muscle fiber. So it becomes a little more smudged. But certainly with IBM, as you can see, because of the chronicity of this disease and its fat replacement, it's very well suited for, ultrasound is very well suited for seeing fibrosis and fat. And it's really been shown that all these white changes that you see in the muscle tend to, with correlating with MRI, really it's produced by mostly fat replacement. So these are some of the typical changes that we can see. So as Pedro showed you, like we tend to look at thighs for MRI, right? Because we're always getting, that's our usual protocol for an MRI myositis. But certainly we know that the deep finger flexors in the hand are affected, and we can easily look at that on ultrasound. So if I'm orienting you here, this is a normal flexor digitorum profundus on the top. This is a flexor carpi ulnaris beside it, and the ulnar nerve over here. With a patient with IBM, you see that selectively the flexor digitorum profundus tends to be affected, and the flexor carpi ulnaris by its side is less affected. And then if this is a normal gastrocnemius and soleus muscle in your calves, this is a normal for reference. Here you have a patient with IBM where definitely it's turned white, and you can see that's the medial head of that gastrocnemius. We can certainly also appreciate asymmetry in different muscle groups. So for example, this is the same patient. On the right side, his gastrocnemius is less affected than the left. And the way we tend to use it also is looking for a predominant involvement. So let's say this is one patient we're looking at, right? If I'm showing you here, this is his deltoid and this is the biceps. They tend to be less affected, although are affected, but they're less affected than, let's say, this is the flexor digitorum profundus, right? So the deep finger flexors in the muscle. And then we can look at the quads, which are also heavily involved in IBM. And you see that his rectus muscle is white already, same with the vastus lateralis, but certainly the vastus intermedius is not as affected. So when you're looking at diagnosis and seeing the affected muscles, then you can say, this is IBM. But really, most of our studies have now shown that when we look at bigger cohorts and earlier disease, looking at which muscle is the most discriminating, one of the most discriminating muscles from mimics is your flexor digitorum profundus or your deep finger flexor. So this is an example of a patient that was sent actually seeing if he had IBM because very, very weak, things are falling off their hands. But if I show you here, this is the flexor digitorum profundus still with good muscle bulk, relatively still black, similar to the FCU on the side. This white thing here is your ulnar nerve, so don't get confused. But as we looked at it, definitely this is not the pattern for IBM. But the other value of ultrasound, obviously, is its real-time capacity. So you're seeing things in dynamic movement. And I hope you appreciated that the muscle was just, twitching. It's what we call our fasciculations. And so this actually led to the diagnosis of ALS for this patient. So it's helpful for looking at mimics. And then the other thing I can tell you that we're also seeing it's very useful for is also understanding more broadly the patient and the muscle quality. So this is, let's say, a normal control again for rectus, and these two patients have IBM. They actually say, both of them will rate similarly on an IBM functional rating scale as we talked about. And yet you can tell here that certainly this patient has much more muscle that's well preserved with little flecks of these whitish fat. But here, this patient really has very little muscle reserve. And so the fat replacement has really been much more dramatic. And the bone is right over here. So a lot of muscle loss. So it's giving us a sense of muscle quality and another parameter upon which to look at patients. It might help us say, which patients are more advantageous to be entered into clinical trials and so on. And so, but that's just a flavor of it because we don't have time. And as you'll see for imaging, it's now part of helpful for diagnostic criteria for IBM. But certainly we can use it if we're talking about fat fraction. Ultrasound is nicely useful for that. And we're doing longitudinal studies and even understanding what's the best parameter for monitoring. And with that, I think we're done with our session and we can take some questions.
Yeah, I don't see specific questions for this section, but we'll move on to the next. And if anybody has question, you can type in the chat. We can answer later. Thank you.
Thank you. Thank you for this incredible session. It was so enlightening and exciting. Thank you. Thank you, Bing. Thank you, Pedro. And thank you, Maima. We're going to move on to the next session, which will be moderated by Dr. Helena Alexanderson, and I'm bringing her up right this minute. and Mr. Joe Sanchez, and I am bringing him up right this second now. Let's see if I can find Helen. Oh, there she is, Helen. Okay, and you can introduce the session and yourself.
Hello, everyone. I'm delighted to be here and to see everyone and to see you, Joe. It was a couple of years ago. My name is Helena Alexandersson, and I'm a physical therapist and a researcher at Karolinska, a university hospital in Stockholm.
My name is Joe Sanchez. I am an IBM patient. I'm known as Myositis Joe on many of the social media sites, and I'm honored to be here. And it's just amazing to be part of this group. Thank you. I would like to introduce Ashley Dalby. Ashley is an clinical exercise physiologist that teaches out of the University of Texas of Tyler. Ashley has shown the ability to improve the mobility and functionality of her patients through a program called Courage Health at the university that focuses on using the power of movement as a treatment for cancer patients, Parkinson patients, MS patients. And now she has been working with myositis patients the last 5 years. I've been under her guidance the last 5 years, and I am proud to say I'm more mobile and functional today than I was when I was first diagnosed with IBM in 2013. And I'm only one of several success stories that's going through her program at the University of Texas of Tyler with the Courage Health program. Ashley has proven with several of IBMers that's under her care that you can improve mobility and functionality with IBM in the right environment. It's yours, Ashley.
Thank you, Joe. Joe is always so complimentary. Obviously, I'm so grateful that I had so many years to work with you and to learn from you, honestly, about myositis. It has been a very, very challenging thing to work with. But from previous research that has been done by other locations, not by me, we know that exercise with IBM is safe and that it should happen, and that there are obviously some very real limitations and some very understandable challenges to exercising with IBM. However, the people that you see in these pictures, not everybody has IBM in these photos. Actually, just one person doesn't, but we've been able to incorporate a lot of very simple techniques and a lot of very limited equipment, and try to make sure that we're gaining strength where possible, but mostly that we are regaining or at least maintaining function. So I wanted to share just a couple of general recommendations with you today, and then give you a little bit of what we do here at Courage Health at UT Tyler. So generally speaking, if I am an exercise physiologist, and I know that we have some physical therapists on the call, some people that have worked in OT before. I think that they would all agree with me. If you are a patient and you are wanting to start exercise and you're really concerned about how do I do that, or you're wanting to just increase the amount of exercise you're doing, if at all possible, I would strongly recommend that you try to work with a professional at least for 1 or 2 sessions, just because we want you to approach it in a really, really responsible way. That professional, whether it is someone who is a personal trainer and has a lot of experience working with folks who have chronic conditions. So if you have a personal trainer in mind, it's okay to ask them, hey, do you have any experience working with someone who has diabetes or with someone who has Parkinson's, or do you have any experience working with more challenging conditions? If someone has experience working in that field, they will probably, hopefully, be able to take the care that you need and do the research to make sure that they are prescribing you very safe exercises. So a personal trainer would be okay as long as they have experience, someone who describes themselves as an exercise physiologist, and then of course a physical therapist or an occupational therapist would be amazing to work with. But even if you just approach them and say, hey, I have money or I have time to pay you for 1 or 2 sessions. So what can we do for 1 or 2 sessions? And the thing would be education, right? That would be hopefully what you get out of those couple of times that you're meeting with that person. But they would be able to essentially do some baseline evaluations with you and figure out if you are more of a beginner exerciser, more of an intermediate exerciser, meaning that you understand how exercise is going to affect your body and how you feel while doing it, and that you can tolerate maybe a few more minutes of exercise before becoming fatigued. Or if you're a more experienced exerciser and you could tolerate slightly longer periods of exercise, you could do multiple times per week. I would say Joe is a very experienced exerciser at this point, but I have definitely worked with some folks who are very beginner exercisers and they need lots and lots of breaks. But that professional, someone who you can talk to who has experience in the field, would be able to establish some baselines for you in terms of strength for your upper body and your lower body, and establish baselines for your balance. They would essentially be able to figure out what can you handle right now and how do we progress that in the future. And then they would be able to give you really good advice for how to be safe during your exercise. I know that everyone who has my IBM that I work with is terrified of falling. That is their number one thing they want to avoid. So we are as safe as we possibly can, and we make sure that we only are doing exercises where the person feels very confident in their balance and that they have support where needed, whether it is a gait belt that somebody is holding on to, whether it's just someone very near you that can give you a balancing hand really quickly, or a lot of times we use something in our clinic that is like a ballet bar that's attached to the wall. If you're going to start exercising on your own, and you're looking for just some general recommendations, these recommendations that are here, where you would maybe prioritize duration of exercise over intensity. So not necessarily getting more forceful with your movements or trying to lift heavier weights, but just try to lift for a slightly longer time, or think of it as walking, be able to walk for a slightly longer time rather than trying to walk faster. Exercise earlier in the day, or do your stuff that you know is going to be tiring earlier in the day, because if you know you're going to be tired later in the day, we would want to avoid exercising at that time. But a really important understanding is that inconsistency in performance is okay. Joe will tell you, and anybody that I work with will tell you, that some days it feels better than others to exercise, and that we will have like a week where we feel really strong, we feel that we're making progress and that we feel like we're functioning better, and then a couple of weeks later it just feels very off, and it's kind of upsetting. Completely understand that, but that inconsistency is okay, and it's something that you accept and you just roll with it, and keep going. Courage Health gets data with most of their participants, and the data is pretty basic stuff. We do some baseline testing, including hand grip dynamometry. So we look at grip strength, basically. We do a functional reach test, a 6-minute walk test, and then a subjective muscle force test called a neurologic motor exam. And we do those tests. If somebody continues with the program, we do them at baseline. So right when you start, we do it 1 month, 3 months, 6 months, and then 1 year in. A poster that was put together by an honors student here at UT Tyler, and he used data that was already available in our system, and looked at the progression of one of our IBM patients. And so we charted out essentially how is her function looking over the course of a year. this particular patient, she did very basic exercises, which you can see there in the materials and methods. She came in and exercised with us 3 times a week. Most weeks, she would come in and stay maybe about 45 minutes. And that's with several breaks during the activity. And so even with very low level intensity and just kind of casual exercise, but sticking with it at the round 3 times a week for a year, what we see in her function is that her balance improved. That's that functional reach test with the orange line. So over the course of 12 months, her balance had some improvements to it. Her 6-minute walk test had some improvements to it. We do see at 3 months, that test was, those tests were done right after the Christmas break. And so she had been out of our center. We'd been closed for like 3 weeks. And so you can see at 3 months, we have like a dip, but we have improvements, slight improvements, very, very slight improvements in grip strength. And then we have the biggest improvement is a function test. And it's honestly not even a test. It's just something that she wanted to do. She was so afraid of stairs that she had not walked up any stairs in years before she started working out with Courage Health. And one of my clinical staffers encouraged her to just try it. And we set up a very, very tiny staircase to start with, just like 1 or 2 steps. And she worked with it a little bit. And then she eventually started going up a flight of stairs. And so by 12 months, actually by 6 months, she was doing 2 flights of stairs, 24 stairs in a row, going up and going down. And so it is, our ultimate hope is that increase balance if possible, but mostly we want the exercise to be a way for you to feel more confident with a lot of your movements, and to feel that you are capable of doing a lot of things that maybe you didn't think you could beforehand. We're hoping that we can develop some resource pages, a resource web page that would be helpful for folks who can't get to a professional or don't have the ability to work with one on a regular basis.
I just want to say one thing real quick is I'm living proof that her program works. If you can put an IBM patient in the right environment with the right professional things, and we teach us to keep fighting for our mobility and functionality, we can improve no matter what. And the toughest part with us with IBM when we're diagnosed, we were kept being told by the medical field, you can't do this, you can't do that, don't try this. And that's got to stop, because you got to give us hope. And ASHME program gives us, and the University of Texas of Tyler and Courage Health program gives us hope.
Thank you, Joe.
Thank you so much, Ashley. It was very encouraging and inspiring to see how you work at the Courage Health Center. Now we're moving on to my dear colleague, Dr. Malin Regart, who is an occupational therapist and who has done instrumental work in hand function in myositis and in inclusion body myositis.
Thank you. Hello, Malin Regart, as Helene said. Thank you for letting me talk to you this evening, today, this morning, to this night, wherever you are. So this is where I work, where we work at the Karolinska University Hospital, and my name is Malin Regart. So I will talk a little bit as expected about hand function and inclusion body myositis, their consequences in daily life and daily activities, because I'm an occupational therapist, I can't not do that, and have some ideas on what can be done for compensatory strategies or technical aids, and also encourage you to do hand exercise. We have already heard, of course, that hand function is affected in IBM, and what happens is that the muscles in the finger flexors get weak, which usually lead to a difficulty to flex the fingers or grasp, and also do the fine motor skills like buttoning shirts or gripping small stuff. But the muscle weakness also can lead to an inability to actively move the joints or the fingers, because the muscles are so weak that you cannot flex. And I will stress that it's still important to also passively maintain this range of motion. We did a study where we checked the grip strength, and we could see that women had approximately 42% and men 30% of compared to the general population, and that the grip strength also were associated to the ability to perform daily activities and quality of life. So that's why I come to this area of the consequences. And we have heard of course, from the beginning about different aspects that can affect how you can perform your daily activities. And we can say that it could affect any of the areas during the day, both the personal care, household activities, work, or leisure. So everything that has to do with you gripping stuff, it could be doing makeup or shaving, it could be cutting food or doing your laundry or eating at a restaurant or be social with your friends or at work when you work maybe with a computer. So some techniques that you can do if you have difficulty flexing your fingers because of the muscle weakness, you can have like this enlarged grips. There are different, of course, stuff that you can use. You can also go to the hardware store or the what is that called? The building where you buy the when you build houses, you can have this. Yeah, there are different. You can also go to other stores that you would not expect, where you can find stuff that you can make your life easier to enlarge the grips. And if you also have a sticky or a non-slip surface, I just translated it from Swedish. It's probably not the right word, but if it's easier to grip, your brain will not squeeze as hard to keep the grip, and then you will use more or less energy in your hands or the muscle strength. And that is kind of what you have in this fishing gloves. If you also are weak in your wrist and it's hard to stabilize, you can use these kind of splints that are usually used for pain relief, even though that's not the case maybe in this setting. And of course, since I'm Swedish, I chose the IKEA version of the jar opener. This is a nutcracker. You can use that for bottles if you have difficulty opening. And so different ways to adapt or have other ways of doing it, but also altering your grip. If you have difficulties using the pinch grip, you can use maybe the key grip. So we did a study on hand exercise. It's not published, so you can't find it anywhere. But we used a single subject design where the participants were their own controls. So in this phase 1, we did repeated measures, and if you exceeded 2 standard deviation band based on these first measures, and you had 2 after each other or consecutively followed measures, you would have like a true improvement. And these are just examples from the study. It's the key pinch grip from the left hand and the 3 jaw for the right hand. So what we could say was that there were few improvements regarding hand function. No one got worse, indicating that it's safe to do. We also asked the participants to name activity areas related to their hand function that they wanted to improve. And there we could see that 6 of the 9 participants improved in their performance or satisfaction in these activities. So someone was talking about function, but it's also the ability to do the things. So in my my suggestion is that you also think of the things you do in your daily life as exercise as well. Do activity training. Usually get better on the things you exercise, and if you want to get better on something, you should do that kind of activity. Saying that, I will talk against me now, because it's also important to maintain the mobility of your hand. And if your muscles are weak so that you can't by yourself flex the fingers, it's still good for you to passively do the mobility training as long as it doesn't hurt. You should also do strengthening exercise if you're weak, and also maybe to prevent or maintain your ability. Once a day is preferable, and also use your hands in your daily activities. So I think we're going to share these slides afterwards. I'm not going to go through these different movements, but these are the ways how the hand or the joints can move. And if you have difficulties doing it actively, you can also do it passively. Doing the exercise or the strengthening exercise, it's good to also have a little bit of a challenge. So when you're done with your exercise, you should be on a 4 or 5 of this scale of exertion, so somewhat hard to hard. And choose a ball or a dough when you do the exercise that is hard enough for your strength. These are also some exercises that you can do, and I have chosen the most commonly used grips that we use in daily life. Is we grasp our hands, we use the pinch grip and the 3-jaw pinch, and we also use the key grip quite a lot. And while we're doing it, we can't then forget the thumb, so we do also the thumb exercise. Yeah, thank you.
Wonderful.
Thanks to all the contributions from the registration. There have been a lot of discussion about an IBM resource page that we are going to be presenting to our board. And so very much looking forward to discussion at the end of this session. We now welcome our next moderators for the coming segment, Roland Mischke, patient research partner from Germany, and Dr. Matteo Lucchini from Università Cattolica del Sacro Cuore in Milan, Italy.
Okay, my name is Roland. Thank you, Leslie, for having me on this group here. I'm a patient research partner from Germany, and I'm an IBM patient for 15 years. So now we are coming to the last section of the seminar, Living with IBM. The first topic is swallowing in IBM with Kendria Garant. She works as a speech language pathologist at the University of Pittsburgh, USA. Kendria, the mic is yours.
Thank you. Hi, all. Greetings from Philadelphia. Here in a hotel. I'm hoping that housekeeping doesn't come in, but it really is an honor to be able to present to you all today on a topic that I am truly passionate about. Here are my relevant disclosures, and I've provided slides for later review if you want to go back. I think the reason for this this topic holds true for a lot of us clinicians that are on the seminar, and those of us that have devoted our careers as patient-oriented researchers. It all started, in the clinic room with a patient with IBM, and being a speech pathologist and an evidence-based practitioner is really frustrating when I was trying to go into the evidence in order how to optimize the patient outcomes. And there was, it's kind of lack of awareness, let alone, research efforts towards improving swallowing function in these patients. And that kind of just led to a lot of collaborations over the years. And our lab now at the University of Pittsburgh has a dedicated line of research to evaluate, the upper airway digestive system and thinking about how IBM can affect that over time and what we can do to be a little bit more proactive to prevent those negative consequences. So just some quick overviews of what we know in the literature so far. There was a 40-year population study that was looking at how many patients would eventually develop dysphagia that had IBM, and about 2/3 of them were reporting dysphagia, and about half of them had a feeding tube. And so that's about 3 times more likely than our other idiopathic inflammatory myopathy. So it's quite significant. Unfortunately, unless a provider is specifically asking patients with IBM if they have swallowing disordered symptoms, they're lot likely to report it. So it's definitely under-recognized, underreported, and then unfortunately that means undertreated. And so traditionally, I think more so healthcare providers were looking at it as like, oh, well, that occurs like way later in the course of the disease. But we also know it can be presenting as the initial symptom. And in fact, there's some case reports where the only symptom was a dysphagia, and that could be years prior to onset of muscle weakness that's elsewhere in the body and before then the IBM diagnosis would have been given. We also know that dysphagia can lead to some pretty significant healthcare consequences. So the aspiration pneumonia risk in patients with IBM is about 3-fold. So it is significant. Provided here is just some common symptoms that have been looked at and reported in the literature. I would say one thing that has been frustrating on my end as a speech pathologist is there's been a lot of attention focusing on the upper esophageal sphincter, so right at the top of the esophagus. We know that tends to be a common impairment, but the problem is clinically, and what our lab is showing is that there's a lot more upstream impairments beyond just that. And some of the treatments then that we're doing only for the UES is ignoring and potentially making swallowing outcomes actually worse because we're not paying attention to the other structures that are also involved. So our lab published a review article just seeing like what is being talked about with regards in swallowing and IBM. So I just want to quickly highlight some of the findings from that study. So when we were thinking about how are people assessing, swallowing in IBM, we found that a lot of them were using what we would consider to be the gold standard to evaluate swallowing function, and they were using instrumentation. And this is just one of our gold standard instrumentations is the use of video fluoroscopy or modified barium swallow, and that's what this picture is showing here. So it's like many X-ray pictures being taken so fast that it looks like a video. Unfortunately, though, not a lot of them were using validated measures, so it was really hard to define then the true impairment that was being caused by IBM. A lot of the studies were looking at what was being reported by the patient, so patient-reported outcomes, again, great, but again, a lot of them did not employ a validated questionnaire. And this table is just showing like the most common impairments that were identified. Again, that cricopharyngeal or upper esophageal dysfunction, that's not surprising to a lot of us. But again, there's some other issues that are happening that we also need to pay attention to. So what we decided to do is say, okay, so what is happening if we employ a validated measure to kind of really start defining these impairments? And so with IBM also being in our older populations, we also have to take into account just some typical aging effects and try to differentiate then what really is IBM contributing to. So we took a patient cohort of IBM, matched them with age and sex matched controls. And you can see just really quickly, just visually, that the patients with IBM had a lot more pharyngeal involvement, so things that are happening in the throat. And that's really important to pay attention to because those events are really critical to make sure that what we're swallowing actually goes into our esophagus and not into our airway, and that nothing's left behind. And so I just want to play a video. So this is from a 63-year-old male that I was following for several years. And he was referred to me because the ENT was considering to do a myotomy, which meant they would cut these muscle fibers right here. That was kind of preventing that what he was swallowing to actually get into the esophagus more efficiently. And for those not familiar, this is barium of what you're swallowing, so it looks a little bit darker on x-rays. We can track it, and you could see a little bit trying to go into his airway. I just want to fast forward. So we can try some things immediately to try to help promote clearance, and that's what we are doing here. But this really is the best way. But some of the findings are not just this. He has a pretty wide pharynx because we have loss of some muscle mass here. And because of that, he's really not able to generate those pressures to really help clear what he's swallowing efficiently. So it's taking a lot of time to eat. So because he was having these additional issues, we actually decided that a myotomy would not be appropriate for this patient. And we actually started him on some low intensity exercises, and we're titrating him up as he was tolerating. And fortunately, he was actually able to resume a full oral diet without any pulmonary complications. We know that IBM is a complex multifactorial disorder, and we think that along with the environmental factors, in addition to typical aging, all that can impact and lead to disordered swallowing and the ability to clear the airways. Unfortunately, when dysphagia is identified, it can be really difficult to know what would be the best management practices because there's very limited evidence available. And so there's been a lot more discussion involving more invasive techniques, again, like the myotomy, that tends to be a really common solution and discussion within the literature. But those don't come without, pretty significant side effects. And so even when benefits have been reported in the literature, they really tend to be somewhat temporary, but also highly variable across participants. So then kind of figuring out then maybe there are some endotypes that have yet to be discovered and really trying to think about who is going to be most responsive to which interventions. And when you're thinking about behavioral treatments, and I really liked following the last session talking about exercise, because they've talked about the benefits of physical exercise, and they've shown that in the limb muscles. But we also have strengthening programs for our head and neck muscles as well. And so thinking about that needs to be studied further. In fact, there was only one study that made it into our systematic review, and unfortunately, it was a negative study. And then thinking about some of the other common modifications, things like thickening the liquids or altering how solids are provided. Maybe it's more of a softer or pureed kind of consistency. But there's not a lot of evidence to actually show that this is really, really useful, especially with regards to longer term outcomes. So thinking of nutritional benefits, et cetera. So a lot of times in my clinic, we'll try to work together with the patient about how can we reduce your dysphagia symptoms? Like, what are some triggering foods? Let's consume a little bit more liquids to help clear what you're eating. And then all this kind of thinking about, well, maybe what we need to do is start looking at this like we have shifted in our other progressive disorders like Parkinson's disease and ALS, where we actually put them on a proactive exercise regime instead of just thinking about reactivity once symptoms have already appeared. And so that's what we're doing. So we have this beautiful study happening, really led by my doctoral student, using a lot of standardized metrics, really understanding how IBM is impacting swallowing, impacting cough functioning, putting that with the physical activity measures, and then watching that progression over time to really start thinking about where do we go to next? Where's going to be our targeted therapeutic intervention that's really going to help our patients with IBM? So with the lack of that evidence, what would I say we should do? So as of right now, I'd say at least once a year that the myositis clinic should offer a dysphagia or some kind of screening measure to see if a patient is having some difficulty swallowing, and then referring them to a speech pathologist if, say, that screening measure was failed. Thinking about respiratory failure is a huge source. So having that kind of low threshold to perform testing, such as more extensive pulmonary function tests. We also know that pharyngeal collapse can be common in IBM, especially for those that have pharyngeal involvement. And remember, I just said that we are seeing that clinically. So identifying people that are at risk for something like obstructive sleep apnea is also important. And then thinking about involving a gastroenterologist or an ENT, particularly if there's cricopharyngeal dysfunction or that upper esophageal sphincter is not working so much. And then, of course, to the rehab team, myself as a speech pathologist, but also occupational therapist and physical therapist, thinking about trying to keep that independence for those activities of daily living as long as possible. And that includes self-feeding and even oral care. So thank you so much.
Okay, thank you, Kendria. Our next topic will be bladder function, and the speaker is Genevieve Sipkovich. She is working in internal medicine trainee at the Fiona Stanley Hospital, Australia. Genevieve, it's your turn.
Thank you for having me. So this study, I guess, why did we ask the question about, incontinence myositis? And it was actually consumer advocacy that this, and we're very glad that that individual was questioning and vocal about it, because it's led us to a really interesting research journey. So we looked at essentially the prevalence of urinary and bowel incontinence in the Australian myositis population and compared that to the general Australian population. We know that incontinence does affect a large proportion of the general population, and there is physical and psychological effects that are certainly meaningful. I'm going to speak mostly about the results, but just very briefly, we did look at all of the myositis types and compared the myositis types to the general Australian population. And we collected some demographic and wellbeing data as well. However, when we look at who actually participated in our research, 77% of the participants had IBMs. This is actually really pertinent to the IBM population. So our population really did represent that IBM population, with most participants being over 50 as well. So I've actually just narrowed the results to really focus on IBM. So this, just at a glance, you can really see the significance of these results. So looking at incontinence in the IBM population versus the general age-matched Australian population. So separated females from males here, and then urinary and bowel incontinence. So just at a glance, you can see the darker colours being IBM really do significantly outdo the general population. It's a 50 plus population as well, just to make it more comparable. So, to put it into something a little bit more tangible, females with IBM we found were twice as likely to have urinary incontinence than their sort of general population counterparts, and they were four times more likely to have bowel incontinence. And then if we looked at the males with IBM were 2.5 times more likely to have urinary incontinence, and then 6 times more likely to have bowel incontinence. And I suppose another really significant finding that we had was, 67% of all of the myositis patient participants who were affected by incontinence, they'd actually never verbalized it, never sought help. And I think that is similar finding in terms of function that I was hearing before about, having to ask that question specifically. So just briefly, we, something often asked is whether or not disease duration and progression is a factor that I suppose contributes or is correlated with whether or not someone was going to be incontinent. And we found that there wasn't an association between disease duration and those that were incontinent. We kind of explored some other factors that, participants, there was whether or not participants had perceptions around what was contributing to their incontinence. And interestingly, there was, it wasn't necessarily always linked to weakness. And we also looked at some of the free text themes. So just seeing what participants, what the impact was of incontinence if they had it on them, and surprisingly, it was fairly impactful. So I guess following the study, what to from here, we always need to talk about the so what aspect of any research that we do. And I suppose something that came from this for us here in WA was we realized that as clinicians, we need to talk to patients about incontinence and open that discussion and include it in as just a screening question, perhaps, every so often, and just open that, dialogue. And you might not be an expert in managing it, but you definitely have colleagues that are, and patients as the patient, talk to your primary care physician. It can be your neurologist, it can be your GP, and seek support and resources. And a question that I often have been asked by patients through different patient education sessions is, what they can do, I guess, from a practical perspective. And so far, there's no reason to think that standard practice for incontinence wouldn't be helpful for people with IBM as well. So that is comforting to know that there is surely things that that you can do that will help incontinence if you are affected by it. And soon we are, we realized there were some gaps in the knowledge. This was, the first, I guess, research of its kind to look at specifically incontinence and myositis. And so now we are looking at whether or not the IBM disease process actually impacts the pelvic floor muscles, and we'll be looking at MRI images. So that's coming soon, and we look forward to sharing that research and that knowledge with you when we're finished. So thank you.
Yeah, thank you very much. And now we are coming to the last session called Psychological Health. The speakers are Ingrid de Groot and Christopher Graham. Ingrid is from Netherlands, patient research partner and social worker, psychology. Christopher is PhD, clinical physiologist at the University of Strathclyde, UK. The stage is yours.
Thank you, Roland, and thank you, Matteo. Can everyone hear me all right? Okay, I'm looking for Leslie now. She will start my presentation. In the meantime, welcome everyone. My name is Ingrid de Groot, and I'm chair of the Dutch Myositis Group, which is a group run by 6 people representing all types of myositis under the umbrella of Spierziekte Nederland, which is the Dutch patient advocacy organization for neuromuscular disease. Because we're running late and everything is very interesting, I will be as brief as I can and will show you some slides on the Dutch patient survey and quality of life and research priorities in IBM, and in the research about the research agenda for IBM. Next, please. So Spierziekte Nederland has 11,000 members with 120 different neuromuscular disease. Almost 400 of those people have myositis, and 209 of them, so a bit more than half of them, have IBM. One of our aims is to foster effective and patient-relevant research. Do you also see the blocks in the slides, or is it just in my?
It might just be on yours.
Okay, yeah. As long as you're seeing the slides, I'm good. So one of our aims is to foster effective and patient-relevant research. Next, please. Now, to find out what exactly is relevant to patients, patient representatives within our patients organization developed a survey looking at both cure and care. One disclaimer here, this is not scientific research, it's a patient-driven initiative. And I will share some results regarding age. 63% of respondents was 65 plus years of age, and 34% was age 51 to 65. Next, please. So first we asked respondents to prioritize topics regarding diagnosis. Knowing that in many cases people suffer from symptoms for years before being diagnosed, it is no surprise that with over 40%, you're still seeing my, okay, sorry. Yeah, thank you, Leslie. It's no surprise that with over 40%, people would like the diagnostic process to be faster and to avoid delay. Less invasive diagnostic procedures, we've heard about them, the MRI or ultrasound instead of the muscle biopsy would be widely appreciated, and 25% of patients hope for more reliable measurement instruments and biomarkers for diagnostic and clinical trials. Next, please. Next, we asked respondents to specify 5 difficulties or challenges they encounter in daily life as a result of IBM and then rate these in order of importance. And you see here that with 72%, the unrivaled number 1 is reduced mobility. And runners-up with still about half of respondents are muscle weakness and impaired arm and or hand function. Also close in terms of numbers are fatigue and dysphagia. When looking at dysphagia and trouble eating and drinking, the one at the bottom, we learned that although many patients experience swallowing difficulties, they not always experience problems with eating and drinking. That is because many of them either modify their diet or use devices and aids to make things easier, which may be causing underreporting by patients, as just mentioned by Ingrid de Groot. Next, please. Another question was, which topics for IBM in quality of life research are most important? The items in green are matching those of all respondents, so regardless of their diagnosis. And we saw that IBM matches many of those. The highest score in IBM is for research improving arm and or hand function, which is vital for self-care or use of a wheelchair and other devices. Another important topic, because of lack of regular treatment options, is research into the effect of and safety of alternative therapies. Insights in the cause of and dealing with fatigue is important, as is the need to focus on family and loved ones. They often end up as being caregivers, which can be distressing for all parties. There are high expectations and needs for studies on the effect of personalized exercise programs, because there seems to be evidence for effects of exercise in delaying disease progression. And finally, more insights in the effects of diet, mobility and personal care, as well as innovations in and the access to these assistive devices are wished for. Next, please. So in 2023, we developed a research agenda, which is a living document. And I know you will read faster than I can speak. So instead of going over this list, I want to share with you an example of why sharing insights between patients and researchers is incredibly important. Although falling and reduced mobility, as we just saw, is the biggest challenge in everyday life, and most medical textbooks will highlight this as the most disabling symptom of IBM, the number 1 wish for quality of life is improving arm and or hand function, because in daily life, having full use of the hands is crucial for self-care, for independence, and the use of assistive devices. Our aim is to encourage researchers and health professionals to focus on these topics and for us to collaborate closely with them. In this process, it is vital that we, as people with lived experience, are involved in research efforts early on, preferably even from the very beginning or the design of the study. We have, after all, experiential knowledge on disease cause, on disease activity, on relevant outcomes, and so on. Next, please. But what are we talking about exactly here in this research agenda? When looking at cure, no surprise that first and foremost, we hope and aim for a cure or at least a treatment to halt progression. Increased insights in disease mechanisms and disease cause could be helpful in that respect, as would be reliable biomarkers. And as said earlier, patients would really appreciate less invasive procedures if possible. Our general ambitions and unmet needs would be to establish IBM registries and to participate in increased clinical trials and or initiating NIS1 trials. This is a wish because of low patient numbers and the fact that many patients are excluded from clinical trials due to disease progression. Next, please. Regarding care, we can see that many topics touch on a very important point, which is the psychological burden of living with IBM. When registering for this seminar, we asked people what they hope to hear about, to learn, or to have more intense discussions about. And strikingly, many of today's attendees, not surprisingly, mentioned that they want and hope, and I would almost call it they need to know more about the psychological burden of living with IBM. These comments and observations seem to confirm that this slide not just shows the unmet needs in care of Dutch IBM patients and their loved ones, but those of all across the globe. And summarize these would be a decrease and more holistic approach of disease burden, including psychological impact, impaired mobility, loss of independence, to improve quality of care and to improve quality of life, especially focusing on dysphagia, on fatigue exercise program, the development of assistive devices, and very important psychological interventions. And finally, to increase insights in the impact on daily living and psychological impact of IBM. Next. And thank you very much. And talking about psychological interventions, you will now hear Christopher Graham, who is a clinical psychologist and who had done some research on clinical psychological interventions in people with a neuromuscular disease. And I think Leslie will start with.
Thank you, Ingrid. I think that we can pass to Christopher Graham video, I think.
Yeah, okay.
So the trial was called the ACTMIS trial, and we wanted to see if this particular talking therapy could help improve quality of life and mood in muscle disorders, including a subsample of people with inclusion body myositis. So we chose acceptance and commitment therapy, which is about helping people orient their choices in life around what they want instead of living to keep pain away. So it's an acceptance-based type of psychological therapy. If anybody's particularly interested in different types of talking therapy, then I encourage you to have a Google around acceptance and commitment therapy. For now, I've not got a lot of time, so I'm gonna move on to talk about the trial. So we tried a really brief or developed a really brief version of ACT for the ACTMIS trial. It was guided self-help. It involved 4 modules that were sent to participants over 5 weeks, and each module was supported by a phone call from a clinical psychologist. The modules included exercises that were about developing this capacity to know what's important to you and to do more of what's important to you in acceptance of the difficult thoughts and feelings that are a part of that process. Here's a summary of what was included in the module. So the first module involved tasks to become more present in the moment, so mindfulness, be able to notice what your mind does and step back from it, unhooking, be connected to how you want to be in your relationships and in your everyday activities, values, and be able to take a flexible observer perspective on yourself and on your experiences, and ultimately approach yourself with greater kindness and compassion. The fourth module was a recap module where participants were invited to reflect back on their experience of trying out the intervention and note if there was anything that was particularly helpful or epiphanous, and to keep living aligned to that or doing those actions. Okay, so this was the research question we had for the trial. Does a brief self-help ACT, acceptance and commitment therapy intervention, improve quality of life and mood better than standard medical care in people with muscle disorders? We aim to recruit 154 people with a range of muscle disorders, including facioscapulohumeral muscular dystrophy, limb-girdle muscular dystrophy, Becker muscular dystrophy, and inclusion body myositis. We needed participants to be adults of at least 18, have a little bit of distress, and we weren't able to personalize the intervention to a great degree. So we excluded people where there was evidence of current cognitive impairment, or they were experiencing a significant mental health crisis, or currently in therapy. We recruited from UK National Health Service clinics, charities, registries. We took our 154 people and we randomized half of them to the ACT intervention plus standard medical care, and the other half of them to standard medical care alone. We measured quality of life, mood, symptom interference, and psychological inflexibility in the middle of the intervention. That was at 3 weeks. At the very end, 6 weeks. Our primary endpoint was 9 weeks, so a little bit after the end of therapy. And then our long-term outcome was at 6 months. We were able to recruit the sample size that we need. So we had 75 randomized to the, I'm not sure which arm's which, but we had 75 and 73 allocated to respective arms. So what we found was that participants did engage in the intervention. So most attended all sessions. Our therapist delivered the treatment with fidelity, so we can be confident that it was ACT that was delivered. There were very few adverse events, so I suppose you might call these side effects apparent within the treatment group. So there was no evidence of greater occurrence of adverse events in the treatment group compared to the control group, so that speaks to safety. And then looking at our primary outcome, what we saw was this consistent improvement in quality of life across the period of study. And there was a significant difference between the arms in quality of life by the end, with the ACT group doing better, significantly better, which is good. Looking at these results in a bit more detail, we can see that quality of life, INQUAL, improved across the period of study. So did mood, so anxiety got a lot better, as did depression. These are moderate to large effect sizes, which is an encouraging finding from a trial. Psychological flexibility improved, but we didn't see an improvement in physical functioning. We didn't expect to see that. So that again is not unexpected, but we did expect to see an improvement in quality of life, mood, and psychological flexibility. The improvements in outcome were retained at 6 months, which is fantastic. So long term, they seem to be still there. The trial has numerous strengths and weaknesses. All trials do. Probably the main weakness to point out is that we weren't able to placebo control in our study. So part of our effect size will be expectancy, I expect. But in a psychological therapy, it's often hard to create a credible control condition.
Thank you, Christopher Graham. Discussions.
I had a question for Kendria, but I think that the question could be responded by other clinicians. Regarding the swallowing problem. Since dysphagia is so frequent in IBM, Ellie, do you think that an instrumental evaluation is needed at least one time at baseline in all of the patients, not depending on the subjective symptoms, just to guide a rehabilitation strategy and to evaluate the presence of at least a mild dysphagia?
Kedria apologized because she's at the dysphagia actually conference. She had to stand by a poster at 11. It varies from one person to the other. In my practice, I routinely screen for dysphagia because people can have some involvement that they're not aware of. While, for instance, in contrast, at least in IBM respiratory symptoms, I might just do a baseline, but I only screen for it if there is some suspicion. After I discuss with the patient different aspects of breathing difficulty, having morning headaches, being tired. But for dysphagia, it varies from one person to the other. But in my practice, I routinely screen definitely at baseline, definitely if there are symptoms, and many times every year to a year and a half, we do a swallow evaluation with a barium swallow as well.
I do agree. It's the same for me, since sometimes people cannot be aware of the symptoms. So we can close our session with Roland, and I want to thank Ellie and also Leslie for this fantastic webinar. I think that we enjoy all of the presentations.
Thank you all for staying with us this late. It's difficult to let such a busy program run smoothly, especially with sharing slides. So thank you for those who stayed, and we will hang around for a few more minutes. Leslie and I, we're happy to answer any questions. But if you have anything you need to go, we completely understand. Thank you all. Good to see you all.